Hello, everyone. This is Dr. Hina, and I can see many of my colleagues, seniors connecting to this forum. I am the moderator of this session, and this is the 12th meeting of Young Pediatric Urology, Society of Young Pediatric Urology. We are very privileged that we have our most loved senior Professor Dr. Sardar Tegul with us. Hello, Dr. Sardar.
Hello, everyone. It's my pleasure.
Thank you. Other international colleagues are also there from Czech Republic, Dr. Eva. Hello, Eva.
Hello, Eva. Hello, Eva.
How are you?
Hi, I'm fine. And you?
Thank you for coming, Eva.
I'm
And
happy
from
to be
national faculty, Dr. Naseem. Hello, Dr. Naseem. Very much welcome to this forum. Dr. Sharik from Kidney Center, Dr. Rashid from Liaquat National Hospital, Dr. Jahazev from Tabba Institute. I'm very much thankful to all of you for joining. Today, we have planned to present 3 cases. Each case will be given 20 minutes for presentation and discussion. At the end of the presentation, those who raise their hand will be given the opportunity to respond to the query that is mentioned by the presenter. I can see Dr. Ejaz. Hello, Dr. Ejaz. Thank you very much.
Yes, hello.
Hello. How are you?
Good to see you.
Without,
Good to see you.
okay, so without further ado, I would request Dr. Ariba from Liaquat National Hospital to present her case. Dr. Ariba, can you please share your presentation with us?
Hello, everyone.
Hello, Ariba. You can share your presentation and can start.
So all of you can see the presentation. Hello?
Ariba, I can see your presentation, but not in a PPT mode. Okay, you can go ahead. Is it clear to other participants? Dr. Sharik, can you see Ariba's presentation?
I can see.
Okay.
Okay, I'll start. I'm Dr. Aiba Zahid. I'm a surgical resident at Liaquat National Hospital. Currently, I'm rotating in pediatric surgery department, and I've been given this opportunity by Dr. Hina Yusuf to present this case in front of all of you. So I'll start. So this is the case of an 11-year-old male weighing 28 kilograms, presented in the month of July 2023 in the Ped Urology Clinic at Liaquat National Hospital with the history of left nephroureterectomy performed outside on 22nd of June 2023. He kept experiencing burning during urination for 2 years, and it continued even after the surgery. His parents were worried about recurrent UTIs despite the treatment. So he voids every 1 to 2 hours, and his stream is normal, and he experienced occasional urgency along with burning micturition and occasional dysuria and daily bed wetting. However, he has no constipation or encoparesis, and he has a regular bowel movement. On examination, he's a thin, lean child, comfortable, no syndromic features. He's afebrile. His pulse is 90 per minute with a pressure of 102/88. His abdomen is soft, non-tender. Bladder is not palpable. Nephrectomy wound was 2-inch. There was a 2-inch scar in the left flank region which was well healed, and normal genitalia, circumcised and normal urethral meatus, bilateral descended testes. We delved into his past medical and surgical history to gather more information. So he has a history of recurrent febrile episodes with urinary symptoms over the past 2 years, treated most of the time with antibiotic as an outpatient. His symptoms got worse in the last 6 months with appearance of left leg pain with occasional hematuria. Past records that were reviewed included reports of some lab workup, urine DR, urine culture, ultrasound, KUB, CT pyelogram, MCUG, and renal scan. This was his lab workup. He has a hemoglobin of 11.4, TLC of 8.9, platelets of 280, and his urea and electrolytes were all normal, within normal range. This was his pre-surgery urine DR and urine culture. The urine DR, we can see all the months before this he got operated. He has multiple, all showing the that he was having UTI, and which was also getting treated, but it was not resolving. The culture showed the Citrobacter species in the month of June. However, and that got treated, and in June, which was before the surgery, he had no growth. So this was the CT pyelogram, which was done before the surgery, that showed left kidney with mild to moderate hydronephrosis, relatively smaller in size with areas of cortical thinning, thickening of the wall of the left ureter, mild right-sided hydronephrosis. Urinary bladder appears thick-walled with irregular margins. No calculus in either kidney, ureters, and urinary bladder. His micturating cystourethrogram, which was done in June 6th, this showed bladder with irregular margins, diverticulum arising from the right inferolateral wall of the bladder, grade 5 vesicoureteric reflux on the left side, no structure filling defect in urethra, normal urinary stream, and post-void completely empty bladder. This is the scan. Urodynamics was done on June 13th. Pre-test urine volume was 30 ml. Expected bladder capacity was 390 ml. However, the patient was having the capacity of 168 milliliter. Pressure bladder capacity was 87 centimeter of water. Maximum Q max was 10.5 centimeter water. Maximum pressure during filling was 87 centimeter water. Detrusor overactivity was seen. So the diagnosis of small capacity high pressure bladder was made. Next is DMSA renal scintigraphy was done on June 19 that showed normal functioning right kidney. The right kidney was normal. The left kidney was poor functioning and hydronephrotic with a function of 11%. Right kidney can be seen with the uptake. However, no uptake or minimal uptake seen in the left kidney. This was the operative findings: small fibrotic left kidney with dilated thick ureter. Histopathology report showed atrophic kidney with acute and chronic pyelonephritis and hydronephrosis. Post-surgery evaluation by the operating surgeon: in the first month post-op, the child developed febrile urinary tract infection twice. Urine cultures were done that showed the growth of Klebsiella pneumoniae, which was treated with oral antibiotics as per sensitivity report, and ultrasound was advised. Post-antibiotic urine cultures was negative for any growth. This was the urine DR and cultures report that was done after the surgery, the 2 times he developed UTI. Both the times there were multiple pus cells, and the culture showed growth of serratia on June 28th. And the next, which was done in July, it showed the growth of Klebsiella pneumoniae. The ultrasound, which was done on 17 July, it showed mild fullness in right kidney, thickened and irregular bladder wall with a diverticulum along the right lateral wall and 2 tiny diverticula along the left lateral wall. So if we summarize this case, he's an 11-year-old boy, got a solitary functioning right kidney and a bladder diverticulum on the same side without evidence of vesicoureteral reflux on right. Not reviewed by cystoscopy so far, has suffered 2 post-procedure febrile UTI that have been treated successfully with oral antibiotics and currently has no symptoms. Possible effect of right-sided bladder diverticular on this child. He could develop vesicoureteral reflux in future or distal ureteric obstruction, urinary stasis in the diverticulum and providing a nidus for bacterial growth. Possibility of detrusor sphincter dysnergia, dysfunctional voider, possible harmful effects on the function of right solitary kidney, particularly in long term. We know that evaluation and treatment of any bladder dysfunction should be considered prior to any attempts to treat the diverticulum surgically. Few questions to initiate the discussion. So the first question that we want to raise is, does he need a complete reevaluation in any form, such as a repeat MCUG or urodynamics, or these tests can be replaced with a cystourethroskopy? Second question is, does he need any treatment in form of anticholinergics with or without repeating urodynamics based on the previous urodynamic result? Are urodynamic results even acceptable when bladder has got multiple diverticulum? And the last question is, has he got any indication of surgical treatment of bladder diverticulum in this case at this point in time, or should we be more conservative? And when would a surgical treatment be indicated in this case? So
Thank you, Ariba. Thank you for presenting this case.
Dr.
Hello, Dr. Sharik. Are you saying something?
Yes, it was a very good presentation, and it's a very good case. And one thing I want to say is, I think the problem is the bladder.
yeah.
The problem lies in the bladder. If you don't treat the bladder, the only functioning kidney will also suffer. I don't think it's the diverticulum, it's the bladder. It's a high pressure, small capacity bladder. So I think the patient doesn't have any neurological issues. Spinal cord I think, is fine. But I'm think about this patient. I think it's a high pressure, small capacity bladder which has destroyed the left side of the kidney. Now it is involving, now the same story is come up to the right kidney. If you don't treat the bladder, or we don't decrease the pressure of the bladder, it will end up like the left side. So I just want to say that. Thank you very much.
Okay. Thank you, Dr. Sharik, for your comment. Let's go to our senior faculty. Dr. Sardar is here. Dr. Ijaz is here. Dr. Sardar, just to initiate the discussion, there is a question in front of you that, keeping in mind the diagnosis of neurogenic bladder in this case, which could lead to development of diverticulum in this patient, does he need any reevaluation in form of any repeat investigations such as cystogram or urodynamics? Do you think there is any need?
Well, I think that is a bladder with high pressure and low capacity. I'm not sure the cause is neurogenic. It may be something else. Mainly, maybe infravesical, some anatomic obstruction, or some dyssynergia. You don't need to have neurogenic problem to have dyssynergia in all the cases. So I would certainly do a cystoscopy and see how the bladder, neck, and the urethra is looking like. And I need to make sure that there is no outflow obstruction of any sort. It could be a mini valve disease, or it could be a functional bladder neck dyssynergia. So I think first you need to rule out any anatomic obstruction like a mini valve or any valve, and see how the patient is voiding under anesthesia. You fill in the bladder and you just pressurize the suprapubic area and see how the urine flow is. And you can do many maneuvers to see if this is anatomically obstructed, or is there any bladder neck hyperplasia or hypertrophy that you may need to cut the bladder neck, etc. I am suspecting that there is some form of outlet obstruction, whether it's anatomic or functional. I think you need to work on that. And I don't know if there is any other neurological problem accompanying. Like, is there any lesion on the back or any walking or any other neurologic deficit, any walking problems, anything in the foot or legs?
There is no lesion on the back. There are
Okay.
no motor or sensory issues with the legs. We have not screened his spine with any MRI. But you're right, we should do that as a complete evaluation. It should be a part of his.
Yeah, I would first go with a cystoscopy. I think the cystography is good, as far as I could see. There is a diverticular on the right side, and if you'd been able to fill it up a little more, maybe in the cystoscopy or in the cystography, there may be reflux to that kidney. It may be some intermittent reflux. Evidently, what happened is when you took the other kidney out, which was acting like a pop-off mechanism, you made everything worse, and the patient is suffering from it. And if you can correct the bladder problems either by diagnosing an outlet procedure, put it on anticholinergics, or even Botox and things like that, and maybe things will get better. If not, then you have to do some kind of surgery, which is a difficult one to make. What kind of surgery? The decision part is difficult. Surgery itself may not be that difficult, but
You're right.
I think it's
Thank you.
not been managed well when you did somebody did nephroureterectomy for this case without good evaluation.
Yes. Dr. Khazar, you are raising your hand. Do you have any comments?
Yeah, so a couple of things. So this is most likely a neurogenic bladder sort of appearance, although we don't know the exact neurology without having an MRI spine and all that. But a couple of things. First thing is, whatever we do, there is a matter of urgency because we now only have one kidney. So I think obviously cystoscopy is one option. The other option is to do video urodynamics if you have the facility and ascertain the pressure and all that. Because if it is a high pressure bladder, you need to do something urgently before any definitive surgery like a Botox or something to bring the pressure down and preserve the kidney. Because in this case, kidney preservation is important. I think somebody said, in the presence of diverticula, is urodynamics effective? The answer to that question is probably yes, because these are very small diverticula at the timing. So that probably should not affect your urodynamics. So I think it's a matter of urgency to act on it. Either do a cystoscopy, as Dr. Tagul has said, or do a video urodynamics and ascertain everything and be very sure to jump on it as quickly as possible before the high pressure changes go in back pressure and affect the only kidney. So I think it's quite an urgent situation.
Okay, thank you for your comment. Dr. Ijaz, what's your take on that?
Thank you, Hina, for asking me for my humble review. I concur with Sardar that the basic culprit is bladder, and there is some functional or anatomical obstruction in the urethra. Usually, whenever we go for nephroureterectomy in such cases, we definitely perform cystourethoscopy in the same setting. Apart from the some neuro functional or any anatomical obstruction, one cause of recurrent and high pressure bladder, which we have, which was evident in previous urodynamic. One possible cause of recurrent urinary tract infection in this particular child is could be because of remnant ureter in the on the left side. In the specimen, if you see the whole ureter is not included in this specimen. So I suspect that there is a significant ureter is left, and we know that one of the possible cause of recurrent urinary tract infection after nephrectomy is because of ureteral stump. So that should be evaluated by a repeat MCUG. And apart from that, in the sequence of even now should be, now you should repeat MCUG at least to see any residual stump. And definitely, as Sardar has suggested, cystoscopy is mandatory in all such cases. And I also concur with Fizzer that if you have the facility of video urodynamic, it's available because we have in your hospital there is a fluoroscope. You can do video urodynamic any time. So it is, and remember that it could be a reflux on the right side as well, which is not evident in MCUG, but we know that almost in 20% cases, when it is not MCUG, the reflux can be missed on the right side. So it should always also, although I think in DMS scan there was no scarring on right side, but you need to repeat it because he is suffering from the urinary tract infection. It could be some new onset scarring on the right side as well. Thank you.
Thank you. Thank you for your comment. Dr. Jahazeb from Taba, what's your opinion on this case, particularly on question number 3? When would a surgical treatment be indicated in this case?
Thank you, Dr. Hina. I totally agree with Dr. Taikul. The main culprit for this patient is bladder. And I think the cause of the bladder should be evaluated. If it's a secondary diverticulum, I think the obstruction of bladder should be treated first. And I don't think so. Patient right now needs any surgical treatment for the diverticulum.
Okay. So everybody agrees with the point that bladder needs to be assessed and needs to be treated first before any surgical consideration is made for treatment of bladder diverticulum. Dr. Eva, just to know whether you have any comment on the given case.
So I agree that first evaluation of the cystoscopy, if there are any obstruction, and then I will take anticholinergics, and at least after 3 months of using anticholinergic, re-evaluation, probably by the uroarmic, and then thinking about something surgical after this.
All right. Dr. Rashid.
Thank you, ma'am. It was a good presentation. Yeah, as Dr. Eva said, actually, the thing is that if we'll go for cystoscopy first and we'll see any outflow obstruction and treat it, then if there is no obstruction and we have to manage bladder first with the anticholinergics, then there is a good option of Botox, but surgery is one of the main thing. If the Botox will not be contributing with anticholinergic, then yes, augmentation would be the answer. If you will see any outlet of no outlet obstruction with high pressure bladder, and there is
You're saying augmentation?
Yeah, if the patient is not responding on anticholinergic and with despite of giving Botox, then yes, surgical option will be there. Augmentation will release his high pressure into low pressure, and you can save the kidney. Otherwise, if the bladder is not responding on that, then yes, you will suffer with another kidney.
Okay, Dr.
Hina?
Fizzer?
Dr. Hina, I agree with Dr. Rashid, because if there is no pathology in the urethra, it's a high pressure bladder, and it has already destroyed the kidney. The patient already lost a kidney. So if no abnormality is found in the urethra, no minival, anything else, then medical therapy can benefit the patient. Otherwise, augmentation this type of patient may end up in augmentation cystoplasty.
Okay. Dr. Khizar, any point to make?
Well, I mean, can I make a comment?
Sure, Dr. Sardar.
Yeah.
Please go ahead.
Well, eventually the patient may need augmentation, but it's a bit too early to make that decision, or at least presume that there may be indication of it. I think we first need to use every other treatment modality that we have to reduce the bladder pressure, and And also something I missed on the urodynamic. Have you been able to see the urodynamic curve? Was it hypocompliant bladder or just hyperactive bladder, like many uninhibited contractions? So if there are many
there were uneven contractions. He had
okay.
You mean to ask about detrusor overactivity, repeated DOs
Yeah,
appearing on the
mainly
there were many.
overactivity. I think anticholinergics or Botox would work quite well, and we can avoid augmentation. If it's just a thick wall bladder and the curve is steeping up and going up high without any pikes of uninhibited contractions, then of course augmentation would be more likely to take place in the future. If you're going to do augmentation, like you just said, there may be a stump left there, and we can use the stump of the ureter to do ureteric augmentation. And in such a bladder, when the capacity is not that bad, considering his age, we can just put a ureter, a detubularized ureter, preserving the distal end of it for the vasculature. You can get good control of the capacity and the pressure by doing just ureterostoplasty. Anyway, but this is an early decision to make. We need to see the cystoscopy and the urodynamics and the response to the anticholinergic treatment, and also maybe Botox.
Thank you. Thank you very much. Dr. Hizar, any point to make?
Yeah. So two things. First thing, I think someone during the discussion said that we can give a trial of anticholinergics. I think I won't agree with that. We need to first try and as quickly ascertain the pathology as possible. Because I think if we go in months and months of trying different things, we can have serious detrimental effect on the other kidney. So I think cystoscopy and video urodynamics, whatever you want to do, must be done as quickly as possible. Another important point, which I think people tend to miss very easily, is to make sure that he's not constipated, because that is very important that we make sure that he's opening his bowels regularly, because if he has a bladder issue and if he's constipated at the same time, he's going to worsen his bladder problems and pressure and all those things. So I think that's also very important to address, that we take a good history and make sure that he's opening his bowels regularly. And I think the mainstay is to try and diagnose it as quickly as possible. That's very, very important. And then do whatever anticholinergic trial, Botox or whatever. I think augment is a very, very major decision to take. So it should not be taken at like a drop of a coin. We have to think, and like in most places, it has to be MDT discussion before you go for augment. But short of that, we need to diagnose first. And in the meantime, make sure one thing, which is obviously he has a sensate urethra, but one thing which can be very, very effective is obviously CIC. But with a sensate urethra, it may not be easy in an 11-year-old to initiate CIC. But sometimes with the new Cordic catheters and all that, CIC can be also very effective with overnight drainage in the interim till we investigate. Because the main worry is that we don't want any pressure going to the healthy kidney. So that can be another thought which we can think about. Thank you.
Thank you, everyone, for all the comments. We should move on to the next case because we have to finish this meeting on time also. So I would request Dr. Ehsan to present his case. He's from Kidney Center, Karachi. Dr. Ehsan, please share your screen.
Hello, everyone. I'll just share my screen shortly. Okay. Can everybody see the screen?
Yes, carry on.
Yes.
Thank you. Hello, everyone. My name is Dr. Mohammad Ehsan Rahman. I'm a resident of urology at the Kidney Center, Karachi. Today, I will be presenting a case to you, which is more or less similar to the previous one. We have a 14-year-old female. She's a resident of Karachi. She came to us on the 26th of July this year with a complaint of bilateral flank pain on and off for 6 months. She was on CIC for the last 1 week, and she was doing it around 4 times a day. There was no associated history of fever, nausea, hematuria, retention, or trauma, and fluid intake was around 1 to 2 liters per day. In the lower urinary tract symptoms, she had a frequency of 4 to 6 and nocturia of 1 to 2. Her stream was normal and there were no other associated symptoms. In the past medical history, again, which was non-significant, surgical history was again non-significant, her birth history and vaccination history were all normal. In personal history, she had difficulty in passing stool basically. She had on and off constipation, for which she used to take oral laxatives. Her developmental history was all normal, and in the drug history, she was taking, along with laxative, she was on fosfomycin for the past 4 days, and she was taking tamsuline for 1 month. On examination, we found a young female of average height and build who was vitally stable and sitting comfortably on the bed. On the systemic examination, we basically could not find any significant findings. There was no spinal deformity. The neurological examination was unremarkable. The chest and the cardiovascular examination was unremarkable. In the abdomen, she had a soft abdomen which was non-tender. The bladder was not palpable, and the genitals were normal. She had some investigations done prior to coming to us, in which she had an ultrasound KUB done in the previous year, in which the right kidney was small in size, the left kidney was normal, and the urinary bladder shows picture of cystitis. She had an X-ray KUB which showed no radiopaque shadows. She had a UFM done on the 12th of July, which had a Qmax of 17, and the voided volume documented was 153 ml. She was hence planned for MCUG, a micturating cystourethrogram. This was done in our center. This is the control study, basically. Then we come to the cystogram, which shows diverticuli along with reflux on the right side. This is a picture which basically highlights the micturating part, in which we can clearly appreciate there is some sort of stenosis or narrowing in the urethra. This is the post-void picture, which shows that she had a significant PVR. And this is the printed report that was generated. It shows the bladder the bladder was trabeculated, and it had a small diverticulum in the anterior wall. The right ureter was dilated, and around grade 2 to grade 3 vesical reflux was suggested. And there was a proximal urethral dilatation that was noted, along with a distal urethral narrowing, suggestive of a short segment stricture, and there was significant post-void urine. Based on these findings, the patient was planned for a urodynamic study. The urodynamics was conducted on the 8th of August, in which the patient was explained the entire procedure. All aseptic measures were taken. The urethral and the rectal catheters were placed, and the machine was calibrated. During the filling phase, the first sensation was felt at volume of 22 ml, in which the detrusor pressure documented was 3 centimeters of water. The normal desire documented was at volume of 145 ml, and the detrusor pressure was 59. The strong desire was documented at a volume of 153 ml, and the detrusor pressure documented was 95. And the final capacity was documented as 154 ml. Then moving on, we come to the voiding phase, in which a peak flow of 18 ml per second was documented. The PDAT at that flow was around 70 centimeters of water, and the voided volume was 143 ml. Her post-void residue was 80 ml. The summary of the urodynamics is: the filling phase, a small capacity bladder which was slightly overactive, compliant, and there was no leakage. In the voiding phase, there was a good pressure, there was a good flow, and there was significant post-void residue. Now I would like to have the panel have a discussion with the panel on how to approach this patient. We basically have this patient planned for basic workup and a DMSA, but a DMSA could not be done in the last few days because of inavailability, and hence we plan for a DMSA and further workup to reduce the final cause of her pathology, and then manage her accordingly. If the panel has anything to add, I would be happy to know. Thank you.
Dr. Sharik. Thank you, Dr. Hassan. Dr. Sharik, is this your case? You brought
Yes,
it
this
to
is
the
my
forum?
case.
Okay,
Yes.
what queries do you have in your mind?
Basically, this is a young female. She always, since don't have a low, have dots. Most probably, she had low test symptoms since no. She was recently came to us. Before that, she was put on CIC for the past 2 to 3 months. The issue is that patient is doing CIC 4 times a day, but still it's not enough. Patient pains a significant amount of pain, and according to age, her capacity is low. So our plan is to do the this reflux is basically because this is secondary reflux, most likely due to neurogenic bladder, and I think this is a high pressure, and there is some amount of DSD in this patient also, because his pressure is high and she cannot empty her bladder completely. We
So are
repeat
you
the
sure
urodiametric 2
about,
times.
all right, are you sure about the diagnosis, or you have query related to the diagnosis of this patient?
We are sure that this is a high pressure, but we are little curious that I want to ask the panel if they have for their expert opinion about this case, if we suspect that there is a DSD element also in this patient, because this pressure is adequate and patient cannot completely empty her bladder.
Okay,
This is the issue.
so let's ask the senior faculty. So they must have should have the idea what is the query in the mind of the presenter. So let's go to Professor Dr. Sardar.
Yeah, I think the discussion is similar to the previous case. We need to understand what's happening to the bladder. As far as I understand, there is no neurogenic problem, which is clinically evident, right? And
yes, sir, no neurogenic problem.
Nothing, okay. So, and I see that the right kidney is quite small in size. Have you done the DMSA study, or did I miss it?
No, sir, DMSA currently the radioisotope is there is a shorter radioisotope.
Okay.
In
But
Pakistan,
looking at the reflux, I can see that this is an atrophic kidney. I don't think the function of that kidney is that high. So this is either a dysplastic kidney, or something had happened over time that this kidney has lost its function. And it is also related to, again, a diverticula, but I think that diverticula may be more secondary than being primary. And this is due to the bladder problem. So you need to understand what's wrong with the bladder. I also like to see the urodynamic study curves, what the pressure is like. If it's with pikes, it's overactivity of the bladder. If it's just going up with a steep curve, then it's a bad bladder wall, fibrotic bladder wall. So that will give you a lot of information. So it's always important to see the urodynamic curves also. And if it's hyperactive bladder or overactive bladder, the tissue overactivity, then there's a point in using anticholinergics and Botox if needed. And I also need to understand what's wrong in the bladder neck area. There's something there, which you need to understand very well, which is because the urethra is sort of angulated to one side. It is displaced to one side. And I don't think it's a stricture, but it looks that there's a neuron. Can you show that picture? Yeah. Here, there's something wrong here on the right side. There's something pushing the bladder neck or causing some angulation. And I don't think this is a stricture, but maybe a congenital anatomic problem there, which you need to understand. So I would do a cystoscopy for this case as well. And the left kidney is totally normal, right? There's nothing wrong. No hydronephrosis.
No, left kidney is normal, and in urodynamic there was a slight overactive, but the curve was steep. No
Steep,
major
going
overactive.
up like this?
Yes.
Okay. So I would do a cystoscopy to understand what's happening at this area, because that's not normal. The bladder neck area and the urethra, the status and the position of the urethra is not normal, which you need to understand.
Thank you, Dr. Sardar. Dr. Ijaz, what's your opinion on this case?
Okay. Let me know that what is the symptoms due to which she was put on CIC?
Because
Sharik?
sir, patient was having lower abdomen pain, and the flow of the urine was very low, and patient have the urge to void but cannot empty her bladder, and the sense of incomplete emptying was there, and lower abdomen pain.
That is not mentioned in history. Remember that the cause of pain in flank is not of because of because of bladder. It could be some other reason. And remember that CIC is not a treatment in overactive bladder. It may worse, and the life of the patient will become miserable. In both the cases, the history is a suggestive of if it is overactive, then it is the CIC is going to worsen the symptoms. Hello.
Okay. Yes.
Can you
please.
hear?
Sir, can I comment? Dr.
Yeah.
Ijaz?
Yes, Dr.
Yeah.
Dr.
Rashid.
Rashid.
Let Dr. Ijaz finish his comment first.
Okay. And then remember that in we have two studies in which the bladder was the child was not able to empty the bladder. One was during urodynamics, and another was during MCUG. And remember that whenever you do any study in unusual circumstances, most of the children would not be able to empty the bladder. So to see the proper study to see whether bladder, the child is able to empty her bladder or not is to do to see on multiple occasions after White performs CIC and then see how much volume is she evacuating. And the other thing is that the right kidney is non-dilated. The left kidney is non-dilated. The right one is smaller and it is not hydronephrotic. So the cause of flank pain doesn't seem to be renal in origin, in my opinion. She may be constipated because if you see that in MCUG the bladder is pushed to the right side and there is some fecal material on her left side of the pelvis which is pushing the bladder on the left side. So the cause of pain could be due to constipation rather than a bladder.
Mama, this can someone Bill Murray. Bill
Okay,
Murray.
thank you.
Later on.
I think that the microphone of the person is on. Could you please mute the mic? Dr. Rashid, you were saying something about this case.
Yes, I would like to just add that Dr. Ijaz said that patient is having patient is putting on the CIC. I thought that when it was put on the CIC, the decision was made because its PVR is significant. So somebody thought that its PVR is significant, then we have to put on the CIC. But as the urodynamic studies was done, it's showing that the pressure was high. But despite of high pressure, there is a significant PVR. So in this case, Dr. Ijaz, I would like to ask that if the patient is having the significant high detrusal pressures, but the patient is not emptying the bladder, and there is a reflux over the right side with it makes worsen the kidney. So I don't understand that what would be the option for it. Could be the DSD that it makes that sometimes there is a high pressure, sometimes in the with the high pressure there is a obstruction from the sphincteric area, then it could not complete empty. So we do agree that this is not the option, but what would be the next step after putting the cystoscopy?
Can I answer that question?
Sure, we can take a comment from you.
Sure.
Yeah. So I think the one investigation which nobody has talked about so far, we need to do a thin slice MRI of the pelvis on this patient, because the urethral deviation is very clear, as you can see on the contrast study. So there is some sort of mass effect or some compression on the urethra, and that even with cystoscopy, I think what you may see is that the urethra may be slightly bent, but because we use rigid cystoscopes, it may straighten out as the cystoscope advances. So I think the first investigation in this case is a thin slice MRI, clearly telling the radiologist that we are interested in maybe 3 millimeter slices to see is there any external compression element on the bladder neck or urethra. And that probably will give us the answer. I have a feeling this will be one of those really rare cases with some sort of almost like a case report situation where there is something external compressing on the urethra leading to all these problems. And that can only be picked up on an MRI. And once we get that, we can sort that out and rest of the problems will automatically resolve. I agree with Dr. Ijaz that the degree of reflux does not explain the loin pain. So that may be something else. But I think the first thing before doing anything is an MRI on this patient.
Okay, so let's listen to the point to be made by Dr. Sardar. What's your take on that?
When I look at that cystography now more closely, I see that there's some sort of a filling defect from the right side, giving me an impression of a cystic dilatation, which is compressing the urethra from the right side. You can see maybe it's more black. That's what we all mainly see in boys, but it's not, it's very, very rare in female, but you can see that it's a cystic dilatation of a gland, periurethral gland, what is named as syringocele. It could be such a problem or any periurethral lesion or a anterior urethral valve. This is not common in females, more common in males, but really a good cystoscopy would give you an idea. Well, an MRI would also give you an idea of what's happening, but I think it should be combined with cystoscopy. Even a very good MRI will not be that informative. Sometimes it all depends on how good the MRI images are, and the patient should be under anesthesia. The picture should be taken very thin slices, and you need a very good radiologist in a very convenient condition to be able to name the problem there clearly. You can do it, of course.
Thank you. Dr. Rashid, you were asking something to Dr. Ijaz. Do you want him to make any comment?
Yeah, actually, the thing is that, inshallah, we will do the cystoscopy, and we do agree, as Dr. Fazar said, that the MRI will give you the good idea of why there is a band and all this thing. But the thing is, as I'm said, that the patient is having the high pressure. Despite of high pressure, there is a significant post void, and we could not find any distal obstruction because as we saw in the urodynamic, there is a good Qmax, so it's showing that there is no obstruction over there. So, but despite of all these findings, we are seeing that the patient is having a significant post void with the reflux over the right side, with the diverticulum over the right side. So, what could be the good treatment option for this patient?
Okay.
Dr. Ijaz, what would be the
obvious diagnosis seems to be dysfunctional wider. Okay. Can I continue?
Yes, sir.
Okay. The problem is that without giving anticholinergic, putting somebody on CIC is not a correct decision. Whenever we put somebody on intermittent catheterization, it's important to continue some anticholinergic, and if even then the bladder is not. Remember that the anticholinergic, if it not only relaxes the bladder, it also improves the widening dynamics as well. And if, despite of giving integrant, we can add a blocker as well in these patients. And even then, if there is significant unit residue, which is causing recurrent urinary tract infection, despite of double widening, then we may think about intermittent catheterization. Remember that in our setup, intermittent catheterization is not very easy procedure to be taken. because most of the time the parents do not accept or they do not do it properly.
Very difficult to be accepted in this society. You're right. Thank you very much, all of you, for all the comments. Let's move to case number 3. I would request Dr. Aisha Bakhtiar, who is a surgical resident, to present her case. Dr. Aisha, please share your screen.
Hello, Dr. Hina, I can't hear properly.
Aisha, we can't hear you properly. Aisha? Aisha, can you hear me? Aisha, I can't hear you properly. Could you please reconnect? Okay, or keep it like this. I hope all of you can hear me very well. So Aisha, keep keep scrolling the slides as I present this. Aisha, can you hear me?
Yes, ma'am. Now, I've connected with my phone. I think there was some issue with the mic.
Okay.
So,
Let's go to the
Assalamualaikum, everyone. I am Dr. Aisha, and I'm resident of Liaquat National Hospital, Pediatric Surgery Department, and I'm going to be presenting my case experience.
Aisha, it's too much echo over here.
Aisha, are you connected with your phone?
Yes, I'm connected with my phone.
Okay.
I'm going to disconnect with my laptop.
Okay. Disconnect from your laptop so that it doesn't echo. Okay, Aisha, go ahead with the case presentation, please.
Hello?
Yeah,
Ma'am,
I
can
can
you
hear
hear me?
you properly. Aisha, please start your presentation. We have to finish this meeting on time.
Hina, can you present the case? If you could
Yes, I
see
can present the case, but I need to see the slides. Aisha, can you show me the slides? Make it in the PPT format. Okay, so Aisha, I'm presenting this case quickly, okay, for the audience, because not everybody can hear you properly. So to all of those who can hear me here, this is a case of a 14-month-old child that we experienced managing, and here our patience and assertiveness work. Therefore, we wanted this case to be shared with our colleagues. And this was a 14-month old female child who weighed only 4.5 kilograms. And she came to us in the emergency department on 9th of June with the complaints of fever. Please move on to the next slide. With complaints of fever for 1 week, cough for 1 week, respiratory distress for 3 days. She was vomiting for 3 days, and there was no urine output for 24 to 30 hours. Her birth history was unremarkable. She was born in a hospital with a weight of 2.7 kilograms, and there was no perinatal issues. There were no antenatal ultrasound that demonstrated any issues. Her past medical history was significant of multiple episodes of acute gastroenteritis, and she was repeatedly admitted in the hospital and treated for dehydration on multiple occasions. Rest of the history was unremarkable. Her nutritional history was also a little bit compromised, probably that led to, and repeated acute gastroenteritis episodes led to his underweight issues. When we examined the child in the emergency department, she was a very sick looking child, dehydrated and lethargic. She was tachycardic. She was running fever of 101 degree Fahrenheit. And she was in a labored breathing state with dropping saturation, and she was immediately intubated and was put on ventilator. Her abdomen was tense and distended, but it was not tender. And there was no genitalia abnormality. When we all opened the diaper, it was completely dry. The differential diagnosis at that time was probably she's in sepsis and is going into septic shock with multi-organ dysfunction. Probably this is calculus. This could be calculus anuria, which led to this anuric state. She may have pneumonia because she had a history of fever and cough, and probably pneumonia progressed into sepsis, or maybe it is meningitis which has progressed into the sepsis. So these were the three main differential diagnoses. So while she was being resuscitated in the ER, workup was sent. The investigation included her CBC, where the TLC count was 61,300, and her hemoglobin was just 4.36 grams. Her platelet count was 71,000. She had a urea of 161 with creatinine of 6.2. Her sodium was 136, potassium was 4.6, and bicarb was just 8. Her X-ray did not show any mnemonic patch. Her ultrasound abdomen showed bilateral moderate to gross hydronephrosis with hydroureter, and the bladder was empty on ultrasound. There was minimal ascites with minimal bilateral pleural effusion. Because there was no urine output, we couldn't send any urine DR culture from ER, but we did send a blood culture which later on grew Candida albicans. Her LFTs were normal. Her CRP was remarkably high with increased BNP. So immediate management in ER was infusion of dopamine was started because she was in septic shock, and she was treated in the ICU because she had to be put on the ventilator. Because of the anuric state and bilateral gross hydroureteronephrosis, PCN was planned. And interventional radiology was taken on board, and they put PCN on both sides and draw the samples of urine. The urine was murky. The right-sided PCN grew Candida albicans and E. coli, while the left-sided only grew E. coli. She started becoming better day by day. Her urine output in the right PCN was more as compared to the left PCN, while the Foley also started producing urine. And we reviewed her ultrasound on the bedside, which showed collapsed pelvic ileal system. There was no hydronephrosis, no hydroureter. And as you can see on this lab panel, that her labs improved, her hemoglobin improved because we gave transfusion, her TLC improved because we treated her with sensitive antibiotics, her platelets started rising, and her urea and creatinine gradually became better till 0.83. But the only thing that we were worried was that there was very minimal, negligible amount of urine coming from the left PCN. So once she became better and her CRP got better, and we were reassured, from the ITU team also that she's becoming better, we did became, comfortable enough to do a bedside nephrostogram. And to our surprise, The left side showed a white patch as soon as the contrast was entered into the left PCN. And as you can see on the screen, it was not into the left pelvic calyceal system, it was outside. So the ultrasonologist requested, interventional radiologist requested us to transfer this patient to the interventional suite and to be put, a redo left PCN was performed. And at that time, when the contrast was instilled into the PCN after replacing it, the contrast went into the colon. Therefore, a CT pyelogram was carried out, which showed a renocolic fistula. Aisha, is this the video?
Yes, ma'am.
Okay, can you play it, please? So here you can see the video of nephrostogram, that when the actually it's only showing this image. Actually, when the contrast was injected into the PCN, it pacified the pelvic calyceal system as well as the colon. Okay, next slide, please. So on the CT, there's a fistula between the pelvic calyceal system and the colon. And next slide. Next slide. So we sat tight on this patient. We did not progress for any laparotomy or aggressive surgical management, and we made sure that there is no. We made sure on the nephrostogram that there's no obstruction at the PUJ or at the ureter or at the VUJ or on the bladder or the bladder neck level, and we hope that this fistula would heal without any aggressive surgical management. And we continued to drain the PCN. And we continued her on broad spectrum intravenous antibiotics. She had a readmission because of severe anemia, where we transfuse her hemoglobin, transfuse her back cells, and continued her antibiotic. And after 3 weeks time, we worked her up with MCUG to identify whether there is any reflux. Got a CPC-UC, got a new ultrasound, and PCN cultures were repeated. So this is the image of cystogram. So on a scout film, you can see both sides showing PCN tubes. And this is the filling phase of bladder. Bladder looks a smooth wall. There are no diverticulums. There's no reflux. And the patient emptied bladder very well. And there was no post-void residual. So this was essentially an MCUG, which was normal. A repeat nephrostogram did not show any fistulous communication with the colon. Probably the renocolic fistula has healed by the time this nephrostogram was carried out. And you can see the pelvic calyceal system, ureter and VUJ, and the bladder looks normal. So it was planned that we would first take the cultures from the PCN. If they grow out, if they come out to be no growth, then we would remove the PCN. When after clamping and observing the patient for fever and symptomatology, one by one both PCNs were removed. And later on, ultrasound was carried out that did not show any hydronephrosis. Her blood workups were also normal. Her urine culture grew E. coli, which was treated. And ultrasound only showed mild distal hydroureter, which measures 0.3 centimeter. So far, cases of renocolic fistulas that are available in the literature, only 100 cases have been reported so far. And out of those 100 case reports, there are very few regarding renocolic fistula management in pediatric age group. And those the papers that mention about pediatric age group, they also mention about surgical management, operative intervention in these cases. But we did not go for it and manage the patient conservatively. We would like to know experience of the audience in managing such cases in the past. how did they manage their patients. The reason of presenting this case on this forum is just to share, just to listen to the experience of the audience. So let's start from the senior faculty. Professor Sardar, what's your opinion on
This is a fistula created at the time of nephrostomy placement, right?
it was recognized at that time?
Yeah, I don't think it's a congenital one or anything. It was just created at the time. It's an iatrogenic one. We always like, whenever we put the nephrostomy tube, we always like to have an antegrade study done, make sure that the tube is in the right place, no matter what. And this is our routine protocol, that we need to see that the tubes are in the right place and there's good urine drainage from the collecting system. I think, well, we had some problems through colon tube placements. They all, as far as I remember, 3 or 4 cases, not many. They all healed by themselves by conservative management. You could have put a JJ stent in and take the tube out. That would have helped. I just wonder what was the problem with this patient that caused bilateral obstruction or anuria? Was it some stone disease which passed in time? What was the reason of obstruction, bilateral obstruction that caused anuria? Was it pre-renal?
We do not know, because
Yeah.
the CT cyelogram that was done ever in the management of this patient did not reveal any problems of stone. It was not calculus anuria. So this is still a mystery. What initially happened? Probably that was urosepsis, UTI, leading to acute pyelonephritis, because when we discussed it with the interventional radiologist, because I spoke to him and I said, probably this is an iatrogenic trauma which took place when the PCN was placed on the left side with the on the first time. But he said no, at that time, because we perform nephrostogram every time we put PCN, so we are pretty sure that that is not iatrogenic. Probably that's a result of acute pyelonephritis on the left side that ruptured into the colon in due time. That was a comment by the interventional radiology. If we take that comment as true, probably there are many people raising their hand wanting to make some comments. So let's start from Dr. Sardar. Would you like to comment any other thing?
Well, I think it's iatrogenic.
Suspecting iatrogenic trauma to the kidney.
Yeah.
Hina, can I say something? Yeah.
Sure, Dr.
Yes.
Ijaz.
Yeah. I concur with Sardar that is definitely it is iatrogenic. Then my diagnosis is most probably it was some fungus ball which was causing obstruction, because in urine culture, blood culture, that grew candida. So most probably there was some fungus ball which resolved itself with your treatment. So the cause of obstruction is most probably fungus ball.
I agree with that.
Yeah.
Probably.
Can I say something, Dr. Hina? Yes, Doctor. Yes, Dr. Ijaz, it's you make a good diagnosis. But the thing is, if the fungal ball is there, and as we are seeing in the culture, there is a fungus grow. But the fungal ball is obstructing bilaterally, because we don't have such kind of experience. Just I'm asking from your experience.
Oh yes, I have treated one patient with fungal disorder on that was obstructing both kidneys, and ultimately we need to remove one kidney because that was non-functioning. The other was we saved with DJ stent initially, and that kept on blocking multiple times. Then ultimately we had to remove the fungus ball with through percutaneous route, and it was bilateral obstruction in my experience. That was aspergillosis.
Okay.
Okay, good. So, Dr. Hina, can I ask?
Sure.
Did you start antifungal treatment when you have a blood culture of?
Without even having culture report, we started antifungal, because in pediatric age group, when a child comes with very severe illness, particularly when the child is in sepsis, we routinely start antifungals.
Mhm.
Dr. Khizar, do you have any point to make?
No, I think it was a good case.
So it is a pure 100% an iatrogenic injury. If there's a calyceal rupture in a non-hydronephrotic kidney, it's very unlikely that it will rupture, secondly rupturing specifically into the colon and causing a fistula. This is, I think, too much high flight of thoughts. It doesn't make any sense. And as a rule, if there is a rupture of a calyx, usually it leads to perinephric collection. It usually won't rupture into the colon unless it's an oncological process or something which has been going on for a period of time. So this is definitely an iatrogenic injury. Secondly, to possibly blockage by a fungal ball or some sort of other reason. But I think you've managed the case very well, and it is commendable that with limited resources you have been able to sort of save both the kidneys, and the patient is doing well now. So very well done.
Thank you. Eva,
Uh,
do you have any managing such cases, or have you ever heard of kidney perforating into colon because of infection? Because we all suspected iatrogenic trauma. Right now we are suspecting, and in the past when this case we were managing, we were also
no,
suspecting.
we have iatrogenic trauma like this, but not in this kind of children. I'm pretty sure it's iatrogenic and it's secondary in her problems. Her problems are different, but fungus infection in our patient is very, very rare. It should be hardly long treated with antibiotics or oncology insufficiency baby, because fungus infection is very rare in Europe.
Thank you.
Dr. Hina,
Dr.
Dr. Hina,
Sharik?
one more thing on a lighter note. This is a classic history of very, very bad luck. Patient doesn't have a one-sided fungal ball bilateral. Lightning doesn't strike a single place twice. Patient does a bilateral fungal ball. Plus, we put the PCN, then there is a chronic fistula in the patient, and you found out nothing is normal in the patient. So you can consider black magic in this scenario also.
Well, we actually discussed it with the interventional radiologist that probably I went to him and I said, I'm suspecting an iatrogenic trauma. He said he couldn't. It is not possible because every time PCN is placed, nephrostogram is performed to see if the PCN had caused any trauma or not. So he's pretty sure that this is not iatrogenic trauma. And then he asked me, are there any reported cases where acute pyelonephritis due to any cause, due to any organism has made the calyx rupture into the colon? Well, there are cases, but we cannot solve this mystery right now, whether this is iatrogenic, but this is highly suspected. So thank you everyone for all the comments on the cases. It was a very healthy and very academically enriched discussion tonight. We'll soon meet each other forum again on 10th of September, which is second Sunday of the next month.
Okay,
thank you all. Thank you,
I'm
Dr.
highly
Hina.
obliged to the senior faculty, Professor Sad and Dr. Ijaz, and all my colleagues, my friends who were the part of this meeting. I'm really very honored. Thank you very much.
Bye-bye.
Take good care. Bye-bye.
Bye-bye.